Welcome, everyone. Good afternoon, and welcome to Dr. Birmaher, who is our Grand Rounds presenter today. Uh, we are very excited as part of the Child Division to have Dr. Birmaher with us. And let me just say a few words about him. He is the Endowed Chair in Early Onset Bipolar Disease and Distinguished Professor of Psychiatry at the University of Pittsburgh School of Medicine, and the Director of the Child and Adolescent Bipolar Spectrum Services. He received his medical degree from Valle University in Cali, Colombia, completed his general psychiatry training at Hebrew University in Jerusalem, and child psychiatry training at Columbia in the city. He's a leader in the study and treatment of pediatric mood and anxiety disorders, and his research has concentrated on describing the predictors, risk factors, course, and treatment of childhood onset bipolar disorder. Throughout his career, he has served as the principal, co-principal, or co-investigator for over 25 federally sponsored research grants and projects. He has authored or co-authored more than 480 publications, numerous book chapters, as well as his own book, New Hope for Children and Teens with Bipolar Disorder. And Dr. Birmaher has been the recipient of numerous awards over the years, including the Colvin Prize for Outstanding Achievement in Mood Disorders Research, the Adolescent Award for Research in Child and Adolescent Psychiatry, the Gerald Clerman Senior Investigator Award, and the Lifelong Fellow Award from the American Psychiatric Association. For 4 years and until October of 2018, he was program chair of the American Academy of Child and Adolescent Psychiatry and was recently named counselor at large for the same association. Through his research, clinical, and mentoring activities, he has increased our understanding of the risk factors for mood and anxiety disorders, developed and implemented innovative treatments to improve the lives of patients and their families, and trained the next generation of educators, clinicians, and researchers. And on a bit of a more personal note, I've been very privileged to know and work with Boris during my time in Pittsburgh. He's a very sweet, collaborative, and highly knowledgeable person in many areas. Probably will be very modest as well. But Dr. Birmaher, I give you the stage.
Okay, then thank you, Dr. Salt, and thank you for the invitation and the opportunity. What I'm planning to do today is, like I assume everyone here is a clinician, is to talk about some of the controversies with the diagnosis, because there is still many people who don't believe that this thing exists. Kids cannot have bipolar disorder. But I'm also going to give some examples of what's going on, new findings, which I think will help to solve the controversies. Then feel free to ask questions at the end if you have more controversies or if I didn't clarify something. Well, one question: if I move the cursors, do you see it?
Yes.
Yeah. Okay. Good.
Good.
Okay. Then this is your disclosures, and this is my disclosures. I only have grants and some royalties from books. Then let me start with this, because this is very telling about what's going on with bipolar disorder in children. There are many studies. I'm showing here only 3 studies, and that have been shown over and over and over by different investigators and different methodologies. And when you begin to see like 10 studies, 12 studies, different independent investigators, you begin to believe that something is happening. And as you can see here, there is one 1921 by Dr. Krepling. And if you see, for example, Dr. Krepling, what he used to call manic depressive illness, most of the people are below age 30. Then he had even 20s, 15. And there is another study here in the bottom, exactly the same, is most of the people are below 20. And if the largest study is here, almost 4,000 people. And again, in this study, around like 70% of the people began to have the bipolar disorder before age 21, something like that, and actually 30% below 13. Then, if all the studies for years and years are talking that bipolar disorder in reality, onset, most of the people when they are going to have bipolar is during the adolescent, and some proportion below age 12, 13, why we are not seeing, why people say, I have never seen a kid with bipolar disorder in my life. And I have friends who tell me like that, especially in Europe. And then the question is, maybe they don't exist, it's true, or maybe they are misdiagnosed with many other disorders and mistreated, which is a problem because these kids suffer a lot. Let me quickly show you some cases. And they are true. They are kids who came to our clinic. This one is typical. This is 13. When he came to the clinic, he was 13 years old, and he has classical periods of mania and classical periods of major depression with melancholia. I didn't do this graphic. This graphic was done by his dad, who is an engineer, and he by himself decided to graph the mood of his son. He has these periods of mania. When he gets manic, when he came to us, he was manic. He was running in the school, touching all the girls, telling the principal what to do, correcting how the janitor works, screaming, laughing. And actually, they called the police and expelled him from the school because they were afraid. And it took us a while to work with the school to tell them he has an illness like any other illness. This kid responded very well to lithium. At the beginning, it was lithium and an atypical, and he responded beautiful to lithium. Unfortunately, due to cultural issues, they didn't believe in medications, and he stopped the lithium several times. And every time he stopped the lithium, he has a recurrence of depression and or mania. This guy, Tom, is currently 32 years old. And again, after being stable for many years, recently he stopped the lithium again. He didn't tell us anything, and he got in a severe depression that lasted like 7 months. And now he's doing again well. But again, then he started the illness very early in life, and then he has the typical bipolar disorder. Let me show you another one. He's a 10-year-old, a little bit more difficult to diagnose because this kid came with typical ADHD, severe temper tantrums, attention problems. And he was diagnosed with the famous DMDD, which I think maybe is not a disorder. And then he was treated for these problems for several years with medications and therapy, actually good dosages of medications and appropriate therapy. However, when we began to follow these kids, and sometimes in order to diagnose bipolar, you have to follow the kids longitudinally and for a while. You sometimes cannot do the diagnosis at the beginning because it's a disorder that manifests by periods. Then you have to know the family and the kid well. Then he has periods that he fulfills for major depression, irritability, sadness, isolation. The concentration gets worse, above and beyond of the ADHD. He sleeps too much, he has low motivation, and he has a voice that sometimes that tells him to hurt himself. I asked him if he was pulling my leg, and he said, yes, it might be my imagination, but for me, it looks real. Then this kid has these problems and on and off, but he also has periods that last only 4 or 5 days. Then that he gets very agitated. And in this moment, he is more aggressive at school and at home, very angry and irritable, very silly. He talks a lot, he's very intrusive, hypersexual behaviors at home and at school. ideas of saving the world. He only slept 3-4 hours without feeling tired the next day for 4 or 5 days. And when you see this, you begin to be very suspicious. And then it can be other things, like a person who is using drugs. But in this case, he has these periods of depression, the periods of 4 or 5 days. And then during these 4 days, he constantly write notes. Let me show you the notes. He does this, and then it is, as you can see, Texas, I don't know, Janine, Chicago, Phoenix, Africa, Pittsburgh. Then it begins to have like flight of ideas. That's the way it manifests in this kid. Let me see if I have, I think, yes, I have another one. Then that's what he does. Or hours and hours sitting in the corner. You can see he does math. He talks about everything comes to his mind, ninjas, whatever. And the teachers already know that if he's in this situation, they put him with a lot of paper in one corner of the class, and then he doesn't disturb the class. Then this kid has these periods. Now, because they last 4 or 5 days, we are forced, because of the DSM, to call him bipolar NOS. But again, if he was a little bit more days, and if he was 18 years old, 21 years old, 22 years old, who is not going to diagnose him as bipolar? Then this kid for years was not diagnosed as bipolar. And the main reason he was not diagnosed bipolar is because he's 10 years old. But then again, if you miss this case,
Yes.
if you miss this case, yes, definitely. Okay.
Yeah, I'll send it again.
Yeah, you have to mute your microphone, but I agree with you. Okay, then listen, this kid, for example, he was treated for the ADHD, but we treat him as bipolar, and he responds very well. And then we have to do a lot of what I call like rehab, psychological rehab, because he has so many years of behavior problems and problems at school. Then again, I wanted to introduce these two cases, one that is more typical, but also 13 years old, and one that is 10 years old. And this kid began to have these problems when he was more or less 8 years old. However, I want to recognize that it's difficult to diagnose bipolar disorder in children. Why? One, bipolar disorder by itself can present in many ways. You can see adults and kids who come in a mixed presentation, rapid cycling, with or without psychosis, bipolar 1, bipolar non-specified, and there are different levels of severity. Then the illness is manifesting very different. Then sometimes, even a medical illness, let's say like lupus or syphilis, sometimes when they manifest different, it's sometimes hard to make the diagnosis. But there is also the issue with the kids is that the effects of development in symptom expression, like, for example, it's difficult to diagnose elation in very small kids. Then you expect the kids to be elated once in a while, or grandiose, define grandiose in a small kids. And then it's only when it begins to be too much that you begin to question. Like, for example, a kid here in the United States who thought that he was Spider-Man and jumped from the balcony of the building, like in the third floor, and then hurt himself very badly. And he really believed he was Spider-Man. Or a girl that we were treating, she's 10 years old, and then she stole the checkbook from his father and went to the bank, and it was very angry with the teller because he didn't change a check for $1,000. Then it's beginning to be a little bit too much. But it's difficult because of these things. And also the kid, it's hard to the kid to express her or his own symptoms. If it's difficult sometimes for adults, imagine a kid a very small kid, how they are going to manifest the symptoms. The other thing is how you interpret the symptoms, especially in a small kid. And a big problem is comorbidity. Many of these kids, I wish they come like Tom, the kid that I show you, he was only bipolar. He didn't have ADHD or oppositional defined or anything. He was only clear-cut bipolar. And the symptoms of bipolar were very classic. Then it was much easier to diagnose. But most of the kids who come to your clinics, especially universities, it's like centers of referral, then they're going to have many other disorders. And I put this quickly, we don't have time to go into this. And then I'm comparing here symptoms of mania, ADHD, ODD, and I put the DMDD because many people are beginning to use this diagnosis. And as you can see, look, in black, most of the symptoms overlap, but there are some symptoms, especially they're episodic, at least in our clinic. In order to diagnose bipolar, I need to have episodes. And the episode needs to cluster symptoms. You don't have to have all the symptoms. But for example, euphoria, decreased need for sleep isn't important. If you have a kid who is sleeping 2-3 hours at night and they're not tired the next day, it's strange, it's rare. Okay, grandiosity with the caveats I gave you, flight of idea. Hypersexuality is not super common, but when it's there, you have to rule out bipolar. You have also to rule out history of abuse. But if you see it, and especially if it's episodic, you have to rule out bipolar. Psychosis, I'm talking about the real psychosis, not like a person say, oh, once in a while I hear that somebody's calling my name. Psychosis. Schizophrenia is rare at this age, then you have to rule out bipolar, especially again if it's episodic. Then, as you can see, then it's difficult to diagnose kids for all the reasons, but it's very important to diagnose them because we think at this moment, at least the current studies, that the prevalence of pediatric bipolar disorder 1 and 2 is like 1 or 2%, similar to the adults. If you add NOS, no otherwise specified, it can increase to 3-4%. And I will show you in a moment how important it is to diagnose the NOS. Now, it usually affects a lot the normal developing of the child, and these kids have poor psychosocial functioning on almost everything, school, interpersonal, family, for example, and definitely increased risk to develop behavioral and legal problems and substance abuse, as I'm going to show you, and and is one of the main factors increasing suicidality in psychiatry, both adults and kids, even more than major depressive disorder. Now, given this situation, these facts, we need to know two things. One, who is at risk to develop bipolar disorder? You have kids who come to your clinics. You want to know, is this kid at risk to develop bipolar disorder, yes or not? For the kids who have already developed bipolar disorder, you want to know who is at risk of recurrence and how to treat the new episodes. And something that I will present very quickly because I don't have enough time is also the can we find biological markers? If the diagnosis is very difficult, for some cases, it's good to have some biological markers, but we don't have them. And there are studies, genetic studies and neuroimaging studies. I don't have, again, I'm going to present only something that was recently published in JAMA Psychiatry, actually this month, I think, regarding the genetics of bipolar disorder in children. I will present a little bit. Now, in order to answer these questions, we decided to put together a study called the Pittsburgh Bipolar Offspring Study, BIOS. I'm going to refer all the time to BIOS. And then it's only in Pittsburgh. And then the goal was to see who is at risk. That was the only goal of the study. In order to do this, it's a case control study. We recruit parents with bipolar 1 and 2 and who have children and adolescents aged 6 to 18. But with the time, the parents began to complain that why we are seeing only the kids 6 to 18 if they have small kids who are beginning to have a lot of behavior problems. Then we extended and we began to recruit also children 2 to 5, which we have been doing this study for 20 years. Most of these kids are already adults, or they are like 18, 20s, something like that. And then, but I'm not going to present the data from 2 to 5 today. Now, we match the sample with community controlled parents selected at random and their children. And we try to follow them every 2 years with many diagnostic and dimensional assessments, family function, you name it, almost IQ. And then we have been following them for 20 years, and the retention has been till now like 80%. Again, because it's in Pittsburgh, and then it's in rural areas too, and people are more stable here. Then the parents were like 377, 236 bipolar, 1 or 2, controls 141, and the controls were healthy or have non-bipolar psychopathology. Now, again, because of the time, the take-home message is that the parents with bipolar have more disorders than the control, almost everything, and also the biological co-parents. They have more substance abuse, more anxiety, history of ADHD, etc. Then when we do the analysis that I am going to present, you have to control for the other disorders, because if the kids are having problems, you don't need to say immediately, it's because the bipolar disorder. No, because these parents also have other problems. Besides this, they tend to have lower SES, and they live in neighborhoods with more problems. Then you have to take into account all these variables before you conclude that the kids are having problems because of the bipolar disorder. Now, regarding the offspring, is in total we have 639 kids, 388 is offspring of parents with bipolar, 251 the controls. At intake, the average age was 12, 50% females, 80% Caucasian, and that's a limitation of the study, because then we don't have so many Hispanics and African American kids. Then we have to be careful with the conclusions of the study. And 50% living with both biological parents, which is sad, but that's the reality. And then when we do the analysis, the statistical analysis, we have to control for this, because it's not the same to live with one parent versus two. Then this is the results. And blue is the high-risk children, and in orange is the controls. And the kids have almost everything, you name it. More mood episodes, more bipolar, which I will show more in detail, more unipolar depressive, more ADHD, disruptive behavior, and substance abuse. And actually, substance abuse was low, the prevalence, because most of these kids at intake on average were 12 years old, and actually give a window of opportunity to prevent substance abuse in these people. Now, when we control for all the things that I mentioned, the main difference were like bipolar, unipolar depression, anxiety disorders, and behavior problems. ADHD disappeared. There was no difference between the children of the bipolar and the children of the control. Now, regarding bipolar, and the top is the prevalence, the cumulative rate of bipolar spectrum disorders. Then the top is bipolar 1, 2, and NOS, and the bottom is only bipolar 1 and 2. And then over all the follow-up, around, these curves began to be different at age 10, 12, more or less. And the prevalence is around 23%, let's say 25 in this moment, in comparison with 3% on the control. But then this is like 20 years of follow-up. But these mean that 75% of the kids so far didn't convert into bipolar. Then no, because a kid is, you have family history of bipolar, it means that you're going to become bipolar. It's not, it's most of the kids don't, but it's quite high. It's 25 comparing with 3%. If you only see the bipolar 1 and 2, it's 13% versus 1.5. And 1.5 is what you see in the community. Now, and this is when you control for everything, demographics, family history of other disorders, etc., you still have this difference, and it's very, very significant. As you can see, the p-values are like 1.2, 10 minus 5. Then it's super, super significant. Then with this, we demonstrate that yes, if you have a parent with bipolar disorder, you specifically are a high risk to develop bipolar disorder. Now, when you want to know, you said 25% are going to develop bipolar, but can you help me to know who is at higher risk? And then, by the way, I just noticed that I can put the slideshow. Sorry. Now you see better. Then who is at risk of developing bipolar? And then somebody come to you. You have the first thing that you have to think if the mother or the father have early onset bipolar, this is the one in orange, or late onset bipolar, this is in blue. And then, and it's important, you will see why. And when I say younger or older, let's say it's like around age 21, 23, 24. That's what we call younger. And then here is no symptoms. Then let's say if the kid doesn't have any symptoms, the kid is healthy, this is the risk. It's like 2-3%. If the parents have younger age of onset, then the risk increase. If the kid has anxiety, depression only, then this is the risk. If the parents have early onset, this is the risk. Then I'm going like that. Now, if the kid, look at the last one, have anxiety, depression, mood lability, and so many symptoms, the risk, if the parents are very early onset of bipolar, can go up to 50%. And this is the kids that you have to pay attention. Then, and this is for the group as a whole. This is all the sample together. And if you want to have more details, you can read the paper here at the bottom. And then again, and the manic symptoms are not that the kids are manic. The kids have some manic symptoms here, it's like subsyndromal, I would say, manic symptoms. But with all these cluster of symptoms, those are the kids who are going to be a higher risk. Now, as I said before, these analyses were done for the group as a whole. It's all the group. And then we are very interested to know one patient. If John walks into your office, or Sheila works into your office, or Carmen works into your office, you want to know how you know if this specific person is a high risk. There is not so much in psychiatry about these things, but in medicine, they're beginning to do this with something called risk calculators. Risk calculator basically is a mathematical tool. Let me give you an example. For example, I want to know if I'm at risk to have a myocardial infarction, a heart attack. I want to be sure. Then I go to my physician, he asks my age, my sex, if I have the high blood pressure and the severity of the blood pressure, high cholesterol, if I exercise, how is my data, family history, etc. They put all these factors in a calculator, and then which is available in the internet for free. And then the calculator gives you a risk, a score. And then with the score, you inform treatment. Then you can see your risk to have a heart attack in 5 years is 20%, begin to do something. Or your risk is only 1%, then whatever you're doing is working. Now, the same they are doing, for example, cancer. Like, for example, a woman has like breast cancer and they have to make a decision surgery. And if she needs chemotherapy or she needs radiation, you can put all the factors in the risk calculator, and the risk calculator may say, no, given your age, don't do the chemotherapy. The risk of recurrence is very low. You don't need. Then it's very good. And in medicine, it's being used more and more and more, but not in psychiatry. Then we decided, because we have all the longitudinal data, we did something for children, offspring of parents with bipolar, and you can play around with the risk calculator in this website under resources. And this is the risk calculator. Then these are the symptoms that you have to ascertain, and here are the instruments. Now, it's very important what I'm going to say. The accuracy 70% is not bad. It's actually the same like myocardial infarction, recurrence of cancer, etc., then it's good. But then you need to you have to be a clinician to use this instrument, and the risk calculator needs external validation, because we did it, but we are waiting that other people will reproduce the findings in order to be used clinically. But I think it's something interesting. Now, the thing also that we wanted to know, can we enrich this risk calculator with other data? Then we did an analysis of the genes of the kids. We collected DNA and all these kids and their parents. And this is the data for the parents. And blue and red is the parents with bipolar disorder, and blue is the parents without bipolar disorder. And let me clarify something for the people who don't know what's a polygenic risk score. Most of the illnesses like hypertension, diabetes, and most of the psychiatric illness are polygenic. Polygenic means that there are tons of genes that make an influence. For example, height. Height is very, it runs in families, almost like 90%. But there are almost like more than 1,000 genes that influence your height. The last time I talked, it was 1,000. I think there are now much more. Then with psychiatric illnesses, even more than 1,000. And then when people try to do studies with few genes, 30, something like that, it's hard to prove anything because there are so many comparisons. But now people are taking many genes and then that are related to the illness, and then do something called the polygenic risk scores. And again, this is not I cannot go in detail. If you want to ask more, I can do it. But what we did is we calculate the PRS, the polygenic risk score for bipolar disorder, polygenic risk score for the major depression, polygenic risk score for schizophrenia, and polygenic risk score for ADHD. There are no differences. And even if this looks separate, it's not significant when we adjust for many other variables, then there are no difference. The only big difference is here. Then you can see the parents with bipolar have significantly high scores in the polygenic risk score than the controls. And this is the parents. Look at the kids, exactly the same. This is the children, the offspring of parents with bipolar. This is the bipolar polygenic risk score, and no difference in the other ones, no difference with the genes for unipolar depression, the genes for schizophrenia, and the genes for the ADHD. Then it's exactly the same like the parents. Then if somebody is going to come and say, oh, this bipolar disorder doesn't exist in kids, I have clinical evidence, and now we are beginning to have genetic evidence. And very quickly, this is the way that we think is the transmission of the bipolar disorder. This is the way we see it. Bear with me, I will explain this quickly. This is parental disorder. Look at this arrow here. Then there is a significant association of a parent being diagnosed with bipolar and the offspring with bipolar disorder. But also look here, parent bipolar disorder, as suspected, is associated with increased risk of genetic risk for bipolar disorder. The genetic risk of the parent influence the offspring polygenic risk score, and the offspring polygenic risk score influence the risk of the child. Then there are two paths. There's an indirect path here through the genes, but also there is a direct path that is, at least in this study, is not influenced by genes, which then there are two ways to get the bipolar disorder, through the genes and through the diagnosis of the parent. However, the diagnosis of the parent, it can be the environment that we are not including here. It can be also that we are not included in the polygenic risk score or genes that we don't know. And also, I don't have time, but the polygenic risk score includes only common genes. But there are also genes that they are called rare that are not included in the score. Anyway, this is quite new and it's very exciting. We cannot use this clinically yet. One, it has to be reproduced. Second, we need to have more genetic data in order to begin to use this clinically, but not yet. But this, for research, is extremely good. Okay, with this, I finish the tour about the offspring. And then let me, do I have Dr. Saul, do I have enough time still?
Yeah, you're doing fine with time.
Okay, let me know when you want me to stop, because I can talk and talk. Okay, then now the next study. I already talked about children who are at high risk. Now let me talk about the kids that you already made the diagnosis. What happened with them? And then we did a study called The Course and Outcome of Bipolar Disorder, COBI. I'm going to refer to this COBI all the time in this presentation. The COBI study is a multi-center study. It was done at Brown University in Rhode Island, UCLA, and the University of Pittsburgh. We have also been following these kids for 20 years. We just finished the study. And we were able to include, most of the kids that we include was bipolar 1, DSM bipolar 1, almost 60%, 7% bipolar 2, which happens also in the adult studies that bipolar 2 is always the smaller proportion, and kids with bipolar NOS. And the reason that we were forced to call bipolar NOS because almost these kids didn't have the famous 5 days, 7 days for bipolar 1, 4 days for bipolar 2, then we have to call them bipolar NOS. But many of these kids have problems with functioning, and as I'm going to show now, when we follow these kids over time, most of them, as I said, didn't have the duration, but similar to bipolar 1 and bipolar 2, they have poor psychosocial function, the same prevalence of comorbid disorders, increased risk for substance abuse, the same than kids with bipolar 1, increased risk for suicidal ideation and attempts like bipolar 1, and high family history of mania like the bipolar 1. Now, when we follow these kids over time, about 50% converted into bipolar 1 and 2, especially the ones who have family history of bipolar. Then we reproduce with this study the finding in the prior study in BIOS. Then if you have some subsyndromal symptoms of mania plus family history of bipolar, you increase your risk to develop bipolar. And then this is a completely independent study with a different sample. Now, when we follow them over time, there is an analysis that, because the rating scales that we are using, we were able to do an analysis is like which percentage of the time they are depressed, manic, euthymic, etc. This paper was only 4 years, and this is the kids with the diagnosis bipolar 1, 2 NOS. We follow for 4 years, and these 4 years, 40% of the time during the 4 years, they were euthymic. Euthymic, I means almost no mood symptoms. And 60%, if I add 40 plus 20, 60%, they were clinically affected. Then most of the symptoms were subclinical and 20% were syndromal. Now, most of them were mixed, rapid cycling, and depression. Then, and that's important because if they have mixed presentations, they're more difficult to diagnose. And also, they also more difficult to treat because even in adults, mixed presentations and rapid cycling is more difficult to treat. And more depression, which is exactly like the adults, because in bipolar in adults, most of the recurrence are depressions. In kids, it's exactly the same. And then we were able to compare, we were able to compare this study with an adult study, and then the results are very similar. And then the main difference between the adults and kids is that the kids have more mixed and rapid episodes like the adults. Okay, the other findings that we have quickly are who did worse when we follow them. Kids who started their illness very early in life. Therefore, it's so important to identify and treat them because the prognosis is worse if they are not identified. Things that you already know. People who were less time in remission, people who have more recurrence. Unfortunately, people with low SES, they do worse everywhere, not only bipolar. Caucasian in our sample, for whatever reason, they were doing worse. Presence of subthreshold symptoms during remission. Therefore, clinically, the goal of the treatment is that the kids will do well, not stay with subthreshold mood symptoms, because these kids tend to have more recurrence, comorbid disorders as expected, history of abuse, physically and or sexual. These kids do worse. Then it's important to address this. And family psychopathology, particularly mania. Then you have also to treat the parents to avoid recurrence, or at least diminish number of recurrence. These kids also at intake, this is as only at intake, almost 40% have a moderate to extreme lifetime suicidal attempt, and 15%, look, it was very severe. Now, we have data also follow-up. When we do follow-up, the 40% increase, like 55%, then is very important. It gives us a window of opportunity to prevent suicidality. But suicidality is very common in kids with bipolar disorder. One more reason to identify and treat them early in life. What about substance abuse? The factors that were associated with more risk or suicidal attempts, at least in our study, was older age, more bipolar 1, mixed episodes. Because mixed episodes, even in adults, is a poor prognosis and increased risk for suicidality, presence of psychosis, substance abuse, non-suicidal self-injury behavior. Sometimes people say, it's only like acting out, scratching superficially. Pay attention, it's important. Physical or sexual abuse, family suicidal attempts, poor family and peer relationships was a very important factor. And then even good peer relations even protected against new abuse during the follow-up. What about substance abuse? At intake, 16%, and at follow-up, 32%. Then it was 48% in 20 years. That's half of the sample. That's important. And look at this, at intake, 16%, and look what happened during the follow-up, and this mainly after 4 or 5 years of follow-up. Then again, it's important clinically, because maybe we can do interventions to prevent the onset of substance abuse. Because as you know, once you have one disorder and on top of this you have substance abuse, the treatment gets very complex. Most, like 76% of the kids who develop substance abuse, they were abusing 2 substances. Most of them were marijuana and alcohol, most of them. And the risk factors is typical what we know. It was lifetime alcohol at intake, behavior problems, anxiety, family dysfunction, family substance use disorder, and a lot of subsyndromal mania that was not well treated. Now, we found that the lack of use of lithium equaled more substance use. And by the way, I forgot to mention, we also find that lithium specifically prevented suicidality in our sample. And then we are not the only one. There are like 3-4 studies in adults who also they find that the only medication that prevents suicidality in this patient is lithium. Even no Depakote, no the atypicals, nothing else. It's only lithium. Why, we don't know, but lithium protects. The only problem is that you can ask me, okay, how you are going to prescribe lithium for people who are suicidal. Then if you're going to do it, you have to ask the parents or the partners to manage the lithium, because you don't trust the patient having lithium in their hand. It's quite toxic and an overdose. Now, let me walk you through this analysis. What I showed you before, it was like 40% manic, 40% in depression during the follow-up. It doesn't talk about subgroups. Then we wanted to have see if there are groups of kids who are doing different over time. Then this is the month, and the x-axis is the month of follow-up. It goes from 0 to 96 months. And in here, in the y-axis is the percent of time euthymic. It means the percent of time that the kids are doing well, basically, that they don't have any significant depression, mania, hypomania. And then we find 4 groups. Let me see if this works. No. Oops, sorry. 4 groups. The group in the top, they were like doing well, like it's 25% of the group. They were doing like well 80% of all this follow-up time. They're doing well. The group in the bottom, they're doing poorly most of the time. The green, they're doing is in the middle. And we find an interesting group because it was interesting in the sense that allow us to do extra analysis. The kids in orange, they started poorly for like 3 years, and for whatever reason, they began to do well, and join this group. Then if I put together this group, and this group is almost like 40% of the kids, after 96 months of follow-up, we're doing relatively well. Then it's important to know, because then you can tell the families that there is a group of kids who, despite that they get the diagnosis of bipolar, they do well. And then who are the kids who are doing poorly are the ones with more family problems, family history of psychopathology. The kids have more comorbid disorders, history of sexual or physical abuse. And these kids who don't adhere to treatment, kids who have very low SES. And this is the kids that do poorly and we can help. Then, because this group in orange, it was an opportunity to see these kids are doing poorly. What happened that they improve? Maybe we can apply this clinically and help the kids who are here in purple. Then it was recently published in the Journal of Affective Disorders. I think this month, it was published the last month. Interestingly, what we found is if the parents, this was very significant, if the parents have substance abuse and they improve the substance abuse, the kids began to improve. If the parents improve the SES, the kids began to improve. Then if the parents improve their psychopathology and also her economical and educational condition, the kids improve. And you can ask me, it's a chicken and egg question. Maybe the kids improve and that's the reason that the parents also did well. No, because it's a longitudinal study we were able to see what is the chicken and egg. The first the parents began to improve and then the kids. Maybe the kids have more, if the parents have better socioeconomic status, they got more treatment, they were able to get more medications for the kids, follow through with the treatment that we are analyzing now, less family conflicts, etc. Now, and these kids improve. I think it has a lot of clinical implications. This group that does persistently well has also clinical implications. And if you want to talk this more during the discussion, there is also a group of kids here that we were able to stop their medications and they are doing well. Then let me give you a quick example. A woman who came to us when she was like 12 years old, typical bipolar, typical episodes of mania, typical episodes of depression, and then she was doing very poorly. She also has a severe general anxiety disorders. Then we treat her with medications for bipolar plus fluoxetine. At the time that she came, it was the only Ssri available. And with this combination, she did very well for years. Every time she stopped the medication, she had recurrences. Now, this woman have now 37 years old. For the last 7 years, she's only taking fluoxetine. Every time I stop the fluoxetine, the anxiety comes back, but the manias disappear. And actually, Kraepelin in his studies, remember that in the time of Kraepelin, there were no treatments for bipolar. Kraepelin also have cases like that he described. Then we have an hypothesis, and again, I'm saying hypothesis, that maybe there are kids that the bipolar disappear with age, because we also have kids who are taking 0 medications and doing well. Now, you can come back and say, maybe you did a mistake and you don't diagnose them well, and they were not bipolar. And I will agree with you, maybe, but maybe not. Like the woman that just showed, if she's not bipolar, I will give you my diploma. because she was classically bipolar. But the same happened with many illness in kids. Have you seen kids with seizures at age 5, 6, and when they're 20, no more seizures? And you don't come back and say, oh, you diagnosed the seizure incorrectly. Or kids with arthritis, that they start having arthritis very early in life, and they needed to go to the hospital, corticosteroids treatment, and now they're doing well. What about Tourette's? There are kids that Tourette's disappear. Then why not bipolar? We were taught that bipolar is a diagnosis forever. Maybe it's not so true, because the people who publish these studies is studies in adults, not in kids. Anyway, I leave this to think. I'm going to finish soon, but remember what I talk. All these studies is the overall picture for all the sample. And here, the study that I'm presenting here is 4 groups. But we wanted also to know who is at risk of recurrence. Then we built a risk calculator in which actually you can see it also in the same website, and it's very easy to use, very easy, because it's more or less the same variables that you usually ask. And these are the results of the risk calculator. This is the month of prediction, go from 0 to 60. And here in the y-axis is something called area under the curve. Basically, it's the accuracy of grossly, is the accuracy of the risk calculator. And blue is mania, hypomania. Look, it's almost 90% accuracy at 12 months, 24 months, 36 months. Then we can predict with a lot of accuracy if you're going to have another period of recurrence. Also, for major depression is in green, is less, but it still is very good. It's like 0.75, it's like 75% at 36 months, and it goes up to, yes, it's like, and it's very similar to cardiovascular illness and cancer. And in yellow is any mood, which is around 0.76. At 3 years is almost 0.8. Then, and this risk calculator was recently validated in a large sample of adults with bipolar disorder. It's a large sample of adults that have been, also I think is the Journal of Affective Disorder published the adult risk calculator using exactly the same variables that we are using and the same rating scales. It's a completely independent study, and it works as well as the one that we said. Then we are happy with this risk calculator, and then we will use it for research and hopefully in the future for clinical work when you are seeing kids with bipolar disorder and you want to know who is at risk. Now, the risk of this calculator is, you see, is like begin to be good at 12, 24 months, 36. We just got a grant and we are using something called passive mobile sensing. It's like the kids are going to download an application in their phone, and then the application is all the time checking for movement, how many times they do send a text, how many times they use social media, and they also indirectly can measure sleep. Then the idea will be, if we using the phone plus these variables that we have in this risk calculator, if we can predict immediate risk. It's like if you see the phone and you see things, you will be able to say, be careful, in 1 or 2 weeks, you are a very high risk to have depression or mania. Come back to the clinic often. And we just begin to do the study now. Okay, then with this, I'm going to stop. Everything what I present here is a large group of people involved. It's not only me, I'm only presenting this, and we got, for all these studies, we got only money from the NIMH. Then I think with this is my group in Pittsburgh. And then again, it's a huge effort of all these people working and doing a study for 20 years. And again, we have always to thank the families to stay with us for 20 years, most of them, because the retention rate is very, very high. Okay, with this, I finish. And I don't know if we have time for questions, or if you have questions.
Yeah, Boris, there are a few questions in the chat.
Okay, go ahead. Can you?
So Dr. Coratola is asking about the frequency of bipolar disorder when grandparents, aunts and uncles have bipolar disorder.
we don't have the data. And then in the literature in adults, is like usually it's the rule of like 10 is like you say like for us it's 25%, but then people begin to say like 10 to 25% of adults, if you have a parent with bipolar, it's around 10%. If it's like a second degree relative, begin to be like 5, and it's very far away 3%. And then but there are not big studies even in adults checking this, but when you begin to have far away relatives, the risk drops a lot. It's a little bit more than the general population, but again, it's not like because you have a grandfather with bipolar, you're going to have bipolar.
The next question is, are microdeletions such as 22q11.2 included in the polygenic risk category?
Oh, very good question. Let me explain. The polygenic risk score in medicine and also in our study all includes SNPs, like common variations. It has to be like more than 1% in the population. When it's rare deletions and everything is not included. And this is one of the criticisms that maybe the effect size of the polygenic risk scores is not super high. Even in medicine, diabetes, cancer, and everything, the effect size is small. That's the reason cannot be used clinically. But when we began to have studies with larger samples, for example, the polygenic risk score that we did, it was with a GWAS. GWAS meaning like a full genome study in bipolar patients that was published in 2019. And then the effect size is like 10%. It's not bad. It's similar to cardiovascular illnesses. And then in 2021, there was another study, another GWAS, a new one that doubled the number of subjects. And the 2019, I think it was like 20,000 bipolar adults, and 2021 was 40,000. Then the effect sizing, we reanalyzed the data and we are going to publish in the Journal of Bipolar Disorder. The effect size increased. Then when we are going to have studies with more samples, larger samples, and when the studies are going to begin to include rare genes, and when the studies are going to improve the statistics, then I think this is when the polygenic risk scores maybe can be used clinically. Not yet. I won't use it yet because it's like the effect size is small, then it's not reliable yet. For research, yes, definitely for research, yeah. I cannot hear you.
Dr. Bentman asks, are there characteristics of parental bipolar illness, 1 versus 2, episode number, psychosis, full and sustained treatment response, that predicts the course of illness for their children?
In the risk, we analyzed this and we didn't find it. Then bipolar 2, the problem is that the sample size of bipolar 2, even in the adult sample for us, it was not very high, but we didn't find difference between bipolar 1 and 2. And by the way, in the polygenic risk score and the parents, we didn't find difference between bipolar 1 and 2. And actually, importantly, in the children, we didn't find difference between bipolar 1, 2, and NOS. The kids with NOS have similar polygenic risk score than the bipolar 1, which is extra evidence of how important is subsyndromal presentations. No, we didn't find. For the COVID study, the longitudinally, yes. Then if parental mania and parental like psychopathology in general increase the risk of recurrences.
Okay, Dr. Bentman also is asking about the course of bipolar disorder in kids. Has it changed with the use of SSRIs?
Not that we know. We have so much data that we try to answer this question, but there is a problem when you do naturalistic studies. It's something called confound by indication. Then what happens is that if the kid is not doing well, then you tend to give more medications or certain things. Then you don't know if they're doing worse because the SSRI or because you prescribe it because the depressions were not responding and you decide to give SSRIs. Actually, in our analysis, doing psychotherapy was associated with worse prognosis. Then we didn't publish because people will take this bad and then misinterpret, and the press will misinterpret them, and they're going to don't do psychotherapy because they do poorly. No, the kids who were doing poorly are the ones who have more psychotherapy. Then I hope everyone is understanding it's very hard in naturalistic studies that are not controlled, you don't have placebo, to find out the effect of the medications. When we did the analysis with lithium and other things, we needed it. This analysis has been done in 4 or 5 years. We never wanted to publish this analysis. Then we have to consult with the statisticians here in the United States who specialize in this. And then we were very comfortable with the effects of the lithium. But again, you have to be careful because this is not a randomized controlled trial.
Boris, here's a case. An adolescent presents with first episode depression with irritable mood, no history of mania, hypomania, does have a significant family history of bipolar disorder. Would you be worried about starting an SSRI in such kids? Is there a situation where someone presents with a first episode of depression that you would consider mood stabilizers instead of antidepressants? That's Dr. Zamzani.
It's an excellent question, and we have the same questions that you understand, not because we study bipolar, we don't have the same doubts. Then if the kid is a super high risk and it has all the symptoms I presented before and the parents have early onset, I will be very careful. I explain this to the parents, I explain this to the kid. Besides this, most of the bipolar onsets in adults and also in kids are depressions. You also have manias like some kids that we see, but the first depression is unipolar depression. You don't know if they're going to convert. Then the question is, do you start with a mood stabilizer or you start with an SSRI? First, this is a wonderful research question if somebody wants to do it. It's a multi-center because you need enough patients, but it's a research question. If the kid is very depressed and the risk is not like very high, I prefer to start with an SSRI and observe and follow the kid very carefully. And then if the kid begins to show symptoms of mania, then you have your answer. Hopefully in the future, we will have neuroimaging, which is not, we are doing neuroimaging. We have some findings, not ready for clinical work. It's not like some doctors are doing beautiful, like a neuroimaging and with many colors, and it's not valid. And also genetics, I hope in the future will help. But in this moment, we only have the clinical, follow the kid very carefully. Now, if you really think that the kid has subsyndromal symptoms of mania and plus the family history, you can decide mood stabilizer. Another option is you can do cognitive behavior therapy. There is enough evidence that work. You can do IPT if it's an adolescent too, and treat the depression only with psychotherapy and forget about medications at the beginning. And then, but that's the state of knowledge that we have now. And by the way, if you start, another question that I also can ask all of you, if you start an SSRI and the kid has like manic-like symptoms, does it mean that the kids have bipolar? Then I can answer given the studies that are done, not necessarily, even if the kid has family history of bipolar, because 5 to 10% of the kids who you treat with SSRIs get activated. The same like when have you seen kids that you prescribe Benadryl and they get activated? They don't fall asleep, they get activated, and you don't call them manic. Or do you have friends and when they drink alcohol or yourself, you're dancing in a table, talking very fast, having a lot of bad ideas. You will be sorry the next day. You can have like hypersexual behaviors and you're jumping all around. Do you call yourself or your friends bipolar? Not. They reacted like that to the alcohol. The same happened with the SSRIs. Then you have to be careful because we get many kids who have activation with SSRIs, and especially if they have family history of bipolar, they are called bipolar. Now, if you stop the SSRI, and after 2-3 days, the kid continued to be manic, then you begin to think twice if the kid is really bipolar and the SSRIs didn't produce the mania, uncover the predisposition to be bipolar. But again, you have a huge clinical problem, what to do with these kids, because if I think it's hard if you have a kid who have only depression. Are you going to prescribe as the first line lithium? Are you going to prescribe as the first line an antipsychotic? Many parents are going to say no. Think about your own kids or your relatives. You will think twice unless the kid has some high suspicion that they're having some manic symptoms. Because, by the way, there are studies showing that if you have a unipolar depressed adult or teenager, and then they are not responding to treatment, and they have some manic symptoms, even if subsyndromal manic symptoms, this is what DSM now called depression with mixed symptoms, these kids tend to respond less to antidepressants. And this is the kids who are high risk to become manic. Then you can make a decision. There is only a very small study of kids who have subsyndromal symptoms of mania and they didn't have anything, but they have some behavior problems and things like that, and the parents were bipolar, and they randomized them to lithium versus placebo, and they didn't find so much. The only thing they found was that these kids have less risk for substance abuse. Then, however, the sample size was too small to say anything. There are other studies that they call the kids at high risk because they were having mild symptoms of mania, and they treat them with Depakote and atypicals, and they found that work for them. But again, I have a lot of problems with these kids. But if you have high suspicion, then based on, for example, the data that I show, early onset bipolar in the parents, the kid is very symptomatic, some subsyndromal manic symptoms, you can make the decision that you're going to treat them with everything but SSRIs. You can make this decision. And you have to explain the kid and the parents why you're doing this.
So we're going to finish up pretty soon with the question and answers. There's no more questions in the chat. I did have one thing I wanted to ask you, because Gay Carlson recently presented to us about DMDD, and that question usually comes up about any overlap you see between bipolar and DMDD.
Listen, I don't know, this opened the Pandora box. I'm not against the diagnosis of DMDD, but I think it was premature. It was like I call it like a political diagnosis. They put this diagnosis too quickly in DSM. They should have put in the appendix, studied this for 5 years, and then make a decision if they put this as a real disorder or not. Most of the MDD kids, it looks like what they have is severe ODD. And then all the studies of the MDD, almost like 99% of the MDD kids also fulfill for ODD, and a very high proportion have also ADHD. You treat the ADHD and then the DMDD disappear. Besides this, many DMDD kids also have major depression, anxiety. If you treat the anxiety and the depression, you improve the kid. And then we also find out that some kids have DMDD and they don't diagnose them as bipolar. It's the new diagnosis in the field, then people are rushing to diagnose this. Then the MDD, remember, was put in DSM-5 very quickly because people were saying that people were overdiagnosing bipolar in kids, which is true. I agree. I spend more time in my clinic undiagnosed bipolar than diagnosing bipolar. But that's what you don't try to solve a problem, creating another problem. Then there are two reasons that they do the MDD. One, because they wanted to diminish the amount of diagnosis with bipolar. Research showing that this is beginning to happen, but with mistakes. And second, they were saying that most of the kids who are taking atypicals are the kids with bipolar, which is not true. Most of the kids who take atypicals are ADHD and kids with behavior problems, because the atypicals are very like, it's like Tylenol for fever or Motrin for fever. They are good to take the irritability and the aggression of kids. Who cares about the diagnosis? Then what's happening now, and you're going to see new studies coming very soon, showing that now most of the kids who receive atypical are the kids with DMDD, which it was expected. And most of the studies now are showing that DMDD is not so reliable, and when they follow the kids, the DMDD diagnosis tend to disappear. Then based on all these things, I think it's premature. I don't use this diagnosis yet. Maybe if we meet again in 5 years, I will say I was wrong. I keep my mind open, but I don't see why we need to use this diagnosis. Most of the kids who come our clinic, our clinic has become like a clinic. It's not only for bipolar, it's for kids difficult diagnosed and difficult to treat. And most of the kids who come with DMDD, I can diagnose them with other things easily. I can diagnose them with major depression, with severe anxiety. We have kids who have come with DMDD, and reality they're bipolar. Then you see now the opposite is the problem. And when we treat the primary diagnosis, these kids do well, and the DMDD disappear. Then if this was a very long answer for something in a nutshell, and you don't have to believe me, but I think I read the research, and I'm involved in the research of DMDD, and this is what is happening. Let's see. It's a question mark. Time will tell.
All right. So we're almost out of time. Are there any last questions or comments people have? There's a number of comments just thanking you, Boris, for the excellent presentation.
Thank you. It was a pleasure.
Okay. Well, let's stop there. And Boris, if you can stay like we talked about and meet with our fellows briefly, that would be great. And Paula, if you want to make me the co-host, the host, that would be fine. Thanks so much, everyone.
Thank you.
I'm going to do that now, Dr. Saul.
Okay, thanks.
You're all set.
All right, thanks.
Nick.
Boris, you still there?
Yeah, I'm here. Can you
Okay.
see me? I'm going to close the slides. Let me see.
Okay.
Yeah, can you see me?
Yeah.
Okay.
So this is mostly our group of child fellows. There's a few other people as well.